Say, get ready, world. It's about that time for Coffee Talk with Slim to James Overton. Excuse me, James Overton on this morning. That's right, with Lady Leah on today, and the Colonel Thomas Chapman. I want you to stay tuned and keep it locked right here to the most talked about show in the radio. Well, before we get on, I just want to say a word of prayer. Father, we just thank you for this day and so many blessings that you have blessed us with. Father, we ask you on today, God, that you will anoint these people. God, that would come across these airways to say what you have to say to those listeners who need to hear what you need to say. Father, we thank you, God, that you have allowed us on today to get up with new mercy. And we're asking you to continue to bless us and guide us as we go through this day, to make ourselves better, to allow ourselves to become better fathers, mothers, and better citizens in this world just for you. We give you thanks. We give you praise. It's in Jesus' name. Amen. And we say a pleasant good morning to you.
Good morning, Bishop.
How are you this morning, Monday morning?
How's everybody doing on today?
Well, we're doing great, man. We appreciate it. We appreciate you opening up with prayer for us. We really need to get this. All right. Every day we rise is a great day to be alive, and welcome to the Seven Cities Forums of Hampton Roads presents Portsmouth Coffee Talk. And we're here today with our host, co-hosts, Leah Drake Stick and Thomas the Colonel Chapman. Good morning. And
Good morning, Slim.
Good morning. Good morning.
Good morning. How was your weekend?
Busy as always for me.
Oh, mine was too busy. Too busy. Can't get it in. I need an extra day.
How about that?
Yes.
Staying safe with your mask and everything.
Yes. Yes.
That goes without saying with this crew here. You know, we don't have to worry about that. It's the other people we have to worry about.
Exactly.
Yes.
All right. Good morning, everyone, and welcome to the listeners on WGPL 1350 AM on your dial. Joining us today, and this morning we have special guests. And before I introduce him, I'm gonna let the doctor introduce himself because I really don't want to mess up his name. I've been practicing, but you all know, if you've been watching, you know I'll mess up Mr. Smith. You know, so I'm gonna let the doctor introduce himself, and so his name will be properly pronounced. Good morning, doctor.
Good morning, everybody. Hope you had a great weekend. I'm Dr. Amin, Yehya, heart failure and transplant cardiologist, and I've been in Sentara for 2 years, coming from Atlanta, and it's a great day to be alive and joining you guys today. Thank you for the invitation, and we're looking forward for our chat this morning.
Thank you. We really appreciate it. And our other special guest, and Brianna, I'll let you introduce yourself, the lady with all the initials behind her name. CCTC, BSN, all that good stuff, you know, so introduce yourself, Brianna.
I'm Brianna Litwin. I'm a transplant coordinator here at Sentara. I've been at Sentara for 9 years, not all of it as a transplant coordinator, but all 9 years within the heart failure program.
Well, we appreciate you here this morning. And we're going to talk a little bit about the Norfolk Sentara Heart Hospital. When I was there, I call it the hotel because it was so accommodating. But we're going to talk about that and other things, and especially the transplant section of the Sentara Hospital, and you know, how it came about. I think it came about like 1989 or 90 or something like that. And before that, you know, they were doing great things in cardiology before they really formed the hospital. And I guess they were doing so great, they said, well, we might as well expand this to a hospital within the hospital. So Doctor, explain, you know, I know you've just been there a couple of years, but sure you know a little bit about the history. How did that come about?
Well, you know, one of the first programs in the region was at Medical College of Virginia, or now called VCU. But there, a lot of our patients in this area were not able to receive that care because of the transportation and the length of like the travels. The leadership at Sentara and came in 1989 and started the transplant program. And it's been a success since then. We've transplanted around 503. We recently did our 503rd patient actually. And since then, we've been providing care for the people in the Hampton Road area. We're up to Northern Carolina and Elizabeth City, and up to Williamsburg, Charlottesville. We have, as you know, Sentara is a healthcare system with more than 12 hospitals that, we serve our patients. So since then, again, we've been providing the best care that we have for the people in the Hampton Road area.
Well, thank you. The Heart Hospital is known for their heart plants, excuse me, transplants, but they do a lot of other things. I know one year, I think it was 2016, they did like a record 19 heart transplants. Brianna, you might remember that. I think it was
actually, more recently, our highest year was a couple of years ago when we were, or it might have been last year, up to I think 29.
Yeah.
Wow.
29.
Yeah.
And
we were 28 last year,
Mhm.
but as you mentioned, it's not just about the transplant. We provide services here. We provide also advanced therapies like left ventricular assist device or mechanical support, because as you know, not everybody is candidate for transplant, or patients might be too sick to receive transplant initially. So what we do is, we bridge either these patients or with a therapy called left ventricular assist device, which is a pump, basically a heart pump implanted inside the body, and it takes the blood from the weak chamber of the heart, the weak pumping chamber of the heart, and pumps it out to all the body organs through the major artery. And with time, we've seen a big improvement in the technology in these heart pumps, and now patients who were not candidate for transplant before or too sick to get transplant at the moment, who used to die waiting for transplant, now they're living much longer with an better quality of life. So we also provide that service here at Sentara, and which is called, again, LVAD. We also provide services like Ecmo, which is kind of like a bypass machine, which is for patients who are really sick and they need support. And in the past couple of months since COVID started, we've seen a lot of increase in those Ecmo support, especially to support the lungs. So we are on the cutting edge of like all the devices, technologies to help populations. So it's a good place to be and to receive care here.
yeah, and doctor, with that LVAD, explain it's different categories people are set in, and you did mention you have the bridge. You have some people. Go ahead.
Yeah, so the LVAD basically, people receive it as a bridge to transplant or as a destination therapy. It's the same operation technically. It's an open heart surgery where the pump is implanted inside the body. And, it has, we call the inflow cannula, where it just attached to the heart muscle of the ventricle, which is the main pumping chamber of the heart. And it sucks the blood out and it pushes it through to the major artery, because, when the heart becomes weak, the heart muscle is not able to generate enough blood flow because the pumping muscle is weak. So what the pump does, it kind of like bypasses that muscle and continuously pump blood to all the body organs through the major artery. So patients will have improved blood flow, they can feel better and live longer. So as you mentioned, Mr. Overton, patients could be either destination therapy, which is they get the VAD and that's all they get, or as a bridge to transplant. Destination therapy, basically patients who don't qualify for transplant, either they're too sick for transplant or they have risk factors that makes them not a transplant candidate. Somebody who says, I know smoking is bad for me. I know smoking can kill and cause like lung cancer and among other stuff, but I'm going to continue to do that.
Mhm.
I know, my diabetes might not be better controlled, or if somebody has malignancy or cancer. So all these things, that certain types of malignancies that does not make them a good transplant candidates. These patients in the past, they were turned down and they used to pass away and die. But now with the LVADs, these patients are living longer. So that's what we call destination therapy. And bridge to transplant is, on the other hand, it's just like want to support these patients until they get their heart transplant, because sometimes patients can get too weak and they can't wait to get their heart transplant. So we put an LVAD for them to stabilize them, getting them better, improve their nutritional support, get them more physically active, because as you know, patients with heart failure, they lose a lot of muscle mass. Patients become deconditioned. Patients, lose their energy and they stop eating because they build more fluid and their appetite goes down. So what happens, their body becomes weak and might be too weak to undergo a transplant, or the way that makes them a good transplant candidate. And here the LVAD comes in, patients will rehab, get better, improve their support, and that will make them a better transplant candidate.
Wow, you just walked me down memory lane there. But I have one more question. I have a question for Brianna. And with all those initials you have behind your name, you're also a transplant and VAD coordinator. So
Yeah.
what is exactly your role? Because you start pretty early. You start with the LVAD patients. And most people now, well, a lot of people are getting that LVAD, as opposed, like the doctor said, some people had to wait in the hospital until a heart was available. And sometimes some people didn't make it, but that LVAD is available now. So you start there with the patients. So what is your role? What's actually your role as the coordinator?
So my role is kind of scattered throughout the pre to post transplant process. In the very beginning, when patients are referred to us and they're sick enough to need advanced therapies as determined by the doctors, a coordinator comes in to coordinate the evaluation process. And James, I don't know if you remember how busy it was, but when we're evaluating patients to see if an LVAD or a heart transplant is a good option for them, it's a very thorough and sometimes a long process of testing and consults. So it just requires kind of a hand in making sure that all gets completed. And then we also, the coordinators do a lot of education. When we start thinking someone is going to get an LVAD or going to get a heart transplant, we start with educating the patient and their family members so they know what to expect before, during, and after. And then currently, probably my heaviest role now as a post-transplant coordinator is educating patients after their transplants on how to take care of themselves, what kind of testing to expect from us. And then heart transplant recipients are assigned a transplant coordinator for the rest of their lives as that kind of resource and lifeline to call at any time if they have any questions.
That's interesting. Interesting. Hey, I'm gonna break in here. Could either one of you address what we used to call the 5-year survival rate? And what does that mean?
So basically, for transplant or VADs, or we can talk about both. In the past, before the 1980s, when the first transplant started, the survival of patients on transplant list, post-transplant, like a year or two. But then the immunosuppression, which is a medication that suppressed the immune response. So think about it. We're putting a new heart in somebody, and the natural response to our body is to reject that heart. Similar thing, if you get like infection or something, our body will mount a response to attack that virus. So our body, when they see a new heart or new organ in, oh, this is foreign, we're gonna get rid of it. So that's why we give them medication called immunosuppressant medications, which are super important for our transplant patients. And patients should not skip these medicines. Why is that? Because the survival rate, to go back to your question, has improved tremendously over time because of the advancements in the medications, and patients are taking these medicines, and the surveillance that we are doing from the medical side to make sure that the organ function has been taken care of, the levels of these medications in our body is within range, and that patients are taking their medicines. So now our transplant patients, the median survival or the 5-year survival, or 50% of patients now are living 13 years on transplant, but they call conditional survival, which is if they survive the first year, which is very crucial for transplant patients. 50% of patients make it at least 15 years. Why the first year is so crucial for transplant patients? Because the body is still primed to attack that organ. The immune system in our, everybody is like super high and alert to attack that organ. With time, our immune system and our response will go down because the body will get used to that organ. So the first year survival, if patients made it the first year, around 50% of patients make it to around 15% for transplant. For an LVAD, it was a great time nowadays for LVADs because in the past, around 70% of patients made it to a year. But now with the technology and the surveillances that we have, the first and second year survival on an LVAD is equivalent to a heart transplant, actually. So patients are living 1 year around 90%, 80 to 90%, 2 years around 80%, and by 5 years, 50% of patients are alive. But again, this has been a huge shift in the past because again, in the past, not many patients made it past 2 or 3 years. And luckily in our program, we have celebrated many patients who made it past 9 and 10 years on LVAD support still, and they're doing pretty well. And again, it speaks highly for not just the patient that they're doing what they need to do, but also for our coordinators that are taking great care of these patients. So again, survival is improving, and I think it's going to continue to get better because more technology is coming down the pipeline for our patients.
Yes. It's interesting though, when you say that, but because, people, we don't talk about the cost of this. And so while I break in and I'll segue into cost. So for those folks that are out there listening to us on the airways and also on Facebook and also FaceTime, we also have bills to pay. And so if you like what you're hearing, you can send a donation or a sponsorship letter to Portsmouth Coffee Talker, P.O. Box 7664, Portsmouth, Virginia 23707. And the other thing now, I'll segue into the cost of the transplant program. We've had a big discussion on the ACA, or what they call Obamacare. And is it correct that within the ACA that there were research dollars tied to GME, graduate medical education, that also helps fund your kind of programs?
I'm not sure about that, but I think, it definitely, there is a lot of support needed for graduate medical education because we're seeing more patients and not enough doctors, and a lot of medical schools, there is a lot of need for graduating more doctors. So any support for the graduate medical education is definitely welcomed. And as you mentioned, this transplant, and Mr. Overton can attest to that. I mean, it's a pretty, expensive procedure because it doesn't stop at the time of getting a heart. It is what comes after too. And, from testing, from taking medications, from transportation, from getting the biopsies or ultrasounds of the heart. But we have here, it's important for every center to have a good financial counselor too, because it walks the patient through, the journey. And the journey of the patients is not through the doctor or coordinator, it's a team. And every institution, they have a team that walks that walk with the patient, and which includes a social worker, which includes a finance coordinator, which includes coordinator, a doctor, administrator. It's a whole team going through it. And sometimes, patients can say, our insurance can cover our transplant, but that overall testing or the medications, it's not covered. And that will be of a big, huge burden for the patients. So,
my next, sorry about that. My next question is for Brianna. So one of the discussions, with the COVID emergency that we've had out there is the lack of trained nurses out here to take care of the numbers of patients. And Slim has talked about all the initials that you have behind your name. And, you know, and I'm a retired critical care nurse. So can you talk about the length of time it took you to get trained in critical care, because you had a critical care background, so that you can take care of these patients, and especially with ECMO machines?
So I I have to admit, I do not have a critical care background.
Okay, okay.
I have not worked in ICU. I went from the cardiac step down floor and then into being an LVAD coordinator and then a transplant coordinator, which are outpatient roles.
Right, okay.
But certainly I am aware of, even here at Sentara, the shortage that existed before COVID, and it is worse now.
Yes, yes.
Do you have a number of patients who are now in your hospital who was impacted by COVID in the heart hospital?
Yes.
Yeah, we have a lot of patients actually, and I was working all the last week and over the weekend, and we've been getting a lot of calls from different hospitals in our sister hospital, and also from different hospitals in the community, trying to transfer patients who need escalated support, such as an ECMO, basically. And unfortunately, some of these patients are, too sick to be, be qualified for this therapy because they've been on support for a long time. And we are running out of beds because of the high acuity and the high number of patients that we've been encountering within our system. And unfortunately, most of the patients who require higher support or on the vent and critically ill are unvaccinated patients. And, and I want to, if y'all let me use your space and today to encourage everybody to get vaccinated. And, because people out there, they say we're immune, we're going to be okay, we're young, but trust me, I've been seeing myself, at least my colleagues, a lot of young patients who are on the vent, and patients have been turning their support down because they become critically ill and nothing much could be done to them. And this theory that we're invincible and we're nothing going to affect us is false. Nothing much can be done to them. And
I'm sorry, that's my phone. Go ahead.
Yeah, I mean, so it's important, if y'all out there listening or watching or viewing, go out there and get your vaccine. It's important. It could be life-saving. And if somebody would argue, oh, we can have some side effect from the vaccine, but your side effect, trust me, will be significantly lower than when you get the disease itself.
Yes.
So go out there, get your vaccine, reach out to your community. There are multiple providers, or even, from CVS, Walgreens, Walmart, all Rite Aid, everybody is providing vaccines. So just go out there and get your vaccine and protect yourself and protect your families. I mean, we've seen families been separated from their beloved ones because people are being lost for the COVID pandemic. So thank you for giving me that.
And Dr. Yehya, please, did I say it correctly?
Yeah, perfect.
Could please, once again, reinforce the fact that the young people are coming into your hospital as a result of COVID-19.
Yes, absolutely. And again, I can speak to it because I've been in this on service like the past week and before too. I've seen young people who are picture of health. Again, I'm going to repeat that, picture of health, very well trained, excellent bodies, and healthy lifestyle, but they get the vaccine. They don't get the vaccine, they get the COVID-19, and they end up on the vent or passing away. We are all predisposed. We have to do our part, wear a mask, always wash our hands or use sanitizers. And also, if we don't care about ourselves, just think about the sick patients out there in the community, because we can always all be carriers. So, we are all in this together. So
Yes.
we are all part of it and affected it. And there's no house or a household that is not affected by the COVID pandemic, be it either losing their jobs or getting affected medically or psychologically or what have you. So to end this pandemic, we all need to get together, get on the vaccine, and try to get over with this nightmare.
And while we're talking about that, recently, I know it doesn't have to do with the heart, but we recently had a delegate, Don Scott, who donated a kidney to Judge Morrison. So I'm thinking that this is a time was important that we discuss organ donations as well. And I know a lot of people are hesitant to sign the donor cards. There's a lot of distrust, especially in the Black community, who feel that, oh, if I get into an accident, they're going to take my heart, they're going to let me die, you know. But it's important that we sign the donor card so that we can help those who may need an organ donation. Could you speak on that, please?
Yeah, definitely. Again, it's important because, you know, after we pass away, we can help save a life, be it a heart, be it a kidney, be it a cornea, be it a skin graft. In this day and time, I think, this organ donation has been regulated and been monitored closely by systems that are, making sure it goes through the right channels, it's monitored, and nothing illegal or inappropriate be done. Everybody's body is being respected because what is more beautiful than giving life to somebody and continuing your legacy through different people too. We've seen it, and again, we've seen younger families who donated, or their son or daughter or family members passed away, but they donated the heart, and we've seen it through the patients who share their experience that the donor family, come back to them, and they feel that their beloved is still with them too and is living along. Mm-hmm. So it's a powerful thing. And again, it's important to be an organ donor because, again, we might save a life, we can bring vision and bring light to the eyes of somebody who has lost his or her eyes. Mm-hmm. So I encourage everybody to be an organ donor. And because, again, if we think about it, we're in a community. We work together, we live together, we meet each other in the grocery store, and we never know when we're going to need one another. And I tell my patients and my colleagues, the table at any time can turn, and we might think we're doing pretty well now, but at that same time, we can be patients too. Nobody's immune. So what I expect from my patients to do, I expect it on myself too. So it's important to be a donor, basically take the vaccines and be a good citizen, basically.
And they can do this at the DMV.
Yes, when you're registering.
Exactly.
Getting your ID. It's an easy process, and it's very much appreciated from somebody who might benefit from it.
Exactly. Thank you so very much.
Thank you.
You know what,
James?
And before we move on, Colonel, before we move on, we're getting about 2 minutes before 7. So we're going to leave the radio station, but we're going to continue on Facebook Live a little longer, if it's okay with you two. If something comes up, let us know. But I just wanted to thank all the listeners on WGPL 1350 for listening. And please join us next week, same time, same station. But we're going to continue on, and appreciate you too, Bishop, for bringing us on the radio. Okay, so we're going to continue on. And Colonel, you will get ready to say something?
Yes, and I'd like to follow up on what Leah and the doctor were talking about as far as heart transplant, heart donations. But the other piece to that is, we talk about donations, is for those folks that to look at also cadaver donations. When you pass away, and then you say a lot of families will cremate you and basically put put your ashes on the shelf or to throw
Yeah,
it in the backyard or whatever. But there is a segment that we need whole bodies to be donated so that we can keep the medical research and also medical education lines going on within the medical schools. And so that's another thing that we need to talk about also.
How does that take place?
Did they drop off?
No, they're there. I'm
Okay,
asking
yeah.
you.
Yeah. I don't know.
Yeah, yeah, and so you can, first is to have that talk with the family, with your family, and saying, when I leave, rather than cremating me,
Yeah.
you can have that ceremony, for at your church or at the funeral home, but my body, rather than sticking me in there and cremating me, donate me to the medical school right here, and it'll go across the country so that my body can be used for teaching this next generation of healthcare providers.
Mhm.
But it goes back to talking and getting by that taboo that I have to go into the dirt because my spirit is already gone.
Your spirit is long gone.
Long gone.
Long
But
gone.
I can also take advantage, be taken advantage of, and that as you see, the doctor, I know he worked on, doing his training program on cadavers. Where did those cadavers come from? From people donating bodies themselves.
Yeah, we are very thankful, definitely, everybody in the medical community and field for every donation and body that's been there, because again, it's a cycle. They're helping progress the care and improve the care and the training for the colleagues. And we are forever thankful for the families and the patients who, donated their bodies to us. I mean, it's definitely, it can be emotional and for some, and it's totally understandable, but we are very thankful for everyone who donates for help progressing the medical field as well.
Okay. Before we go into another section, I'd like to piggyback also on what Leah said. A perfect example of also being a donor. You can be a living donor. And you mentioned perfect example about our delegate over here in Portsmouth, Don Scott, giving his kidney to a local judge here. And Don went home yesterday, and the judge is going home today after their.
That's very powerful.
Yeah.
That's very that sends a big message, and we're thankful for people out there to do that, because they're shedding light on this important topic, and that's very powerful.
And James is so true, and you're so right, because once Don did that, I realized I had not signed the donor card. And then when I did research on the two of you coming in, I know it's something that I need to do. And that will be one of the things on my agenda, to make sure that I do sign the donor card.
Yeah.
And I will remind you.
And you will remind me. But let me ask one other question. And this was a question asked of me. Does it matter whether a Black, Hispanic, or an Asian donor heart is transplanted into a patient of any particular race? Does it make a difference?
No.
Does it make a difference if a female heart goes into a male heart?
Sometimes, depending, it's more the size mismatch that we look at.
Okay.
Not so much gender to gender, but we try to match the size appropriately.
Okay.
Yeah, and to answer that, go ahead, Doctor.
No, I agree totally with Brianna, what she mentioned, because if tall 6'6" male, you need bigger heart muscle to support the body. So we tend to match sizes. In the past though, and that question is very appropriate, female to male hearts was not recommended, and it's been associated actually with increased risk of worse outcomes. But recent studies have shown that if the size appropriately matched, there's no significant difference.
Yeah, and I used to be a part of a support group at the hospital, and one of the people in transplant recipients in there, a male had a female heart. He had received, His voice did change, but no, I'm just joking. Just joking. His voice did get higher, but he's still here. I wanted to bring up this point, and let's talk about prevention, as far as a healthy heart. And it's always been a thing with men, we'll feel something and we try to shake it off. And I've over the years, since I've had gone through my procedure, talked about, paying attention to your signs that your body gives you every day. And, and sometimes women get different symptoms or things of something going on with their heart. But talk about the importance of paying attention to your heart or just being heart healthy to prevent getting to a point where, some heart conditions are history, a part of your history. And you have to know that in order to also be preventative, But talk about some of the things you can do to prevent or to keep up with a healthy heart.
Yeah, definitely. I mean, as they say, nobody knows you more than you do. So when you have to be attuned to your body and listen to your body before even going to a transplant. I mean, there's a major things that could be taken care of and prevent you even getting there. One of them is, for example, blood pressure, making sure that blood pressure is being controlled, because higher blood pressure have shown to be associated with heart failure, with heart attack, with strokes, with all the different outcomes too. So make sure you see your provider, being a primary care physician, and to make sure your blood pressure is controlled. Making sure if you have diabetes, that your hemoglobin A1C, which is a measure how much your blood sugar is being controlled, is controlled. Make sure your cholesterol is taken care of as well. Make sure you exercise. Make sure you eat right. Monitor your caloric intake. Make sure you eat fruits and vegetables. All these things that might seem simple, but they have a huge impact on one's life. Make sure your weight is being controlled as well too. So when these risk factors are not being taken care of, or they become out of control, patients are at a higher risk of developing heart disease. And as you mentioned, sometimes patients can just neglect and don't, listen to their bodies and say, oh, it's just like a indigestion or like a heartburn, and they would be probably having a heart attack. And sometimes they say, oh, we're just getting older, we're getting short of breath, or when we go one flight of stairs, we have to stop to catch our breath, or, when we walk from our house to the mailbox, we have to catch our breath. Oh, it's just we're getting older, or when our lower legs or, our legs start swelling, we say, oh, it's just because we're standing on our feet. These are all signs that something wrong is happening. And just listen to your body. I mean, I'm just going to use this also forum to educate patients about signs of heart failure, which is the most obvious sign is shortness of breath. If you're getting more short of breath with walking or activity, if you're waking up at night because you can't breathe, if you are putting pillows underneath you so you can breathe better, if you're noticing that you're having swelling in your legs, if you're noticing you have more bloating, or you're full earlier on, if you're noticing that you have your belly is distended, and if you notice if you go one flight of stairs or walk a little bit, you have to stop to catch your breath, something is wrong. Something needs to be addressed. And it might be benign, it might be a simple thing, but you should not notice these signs and work them up. And it might be just, high blood pressure that could be taken care of, but also could be something more serious. And last week, actually, I saw a patient while I was on service. He's in his early 30s, and this guy was doing well. Before he was previously healthy. In July, he thought he had COVID, and because he started getting more short of breath, And so he went to the urgent care and they gave him some antibiotics and they told him just like, isolate yourself and it could be pneumonia. This shortness of breath did not get better, came back again. They ordered, chest x-ray on his heart and his heart was enlarged, ultrasound of his heart, and his heart is barely pumping. And now this gentleman who thought he had pneumonia or infection is now dealing with heart failure. And this is how patients sometimes with heart failure come to us. They've been seen by multiple providers before sometimes for shortness of breath, and it thought to be could be from asthma, COPD, pneumonia, bronchitis. And what they usually have is heart failure. So it's, again, and this gentleman, we're taking care of him, but who would have thought a 32 or 30, early 30s gentleman could be struggling with this disease? And to go back, not to repeat myself, from my experience and my other colleagues' experience, not just here, but throughout the country and the world, we're seeing more and more younger patients with heart failure as well in their 20s. And what service we provide here at Sentara is we do genetic testing, and we're seeing a lot of what we call inherited diseases that can affect the heart muscle, which makes it weak. Right. So do not neglect or, just brush any of the symptoms. Just, we are all predisposed. We just need to listen to our bodies and be careful.
Wow, Dr. Hearn, you say that, I felt like I was a poster boy for heart failure. But I want to take you back to the 5th floor for a minute. If you can, follow the yellow brick road. We're going to take you back to the 5th floor for a minute. And nurse, especially on that floor, or any nurse on any floor, but I can relate to this floor. I can recall how personal things got between you and patients. Y'all always made each patient feel like they were the special one. And I know you all showed that same care to everybody. But how as a nurse up there on that floor, and you saw a lot of things happen, and sometimes you saw death, and with someone that you had been with and taken care of, how did you all handle that emotional? Because I know you all were human too. And you all had to do some things to sort of cope with those, because you never showed us. Yeah. I could see some things going out in the hall, and then somebody will walk in like it was a lovely day. Yeah. But I could tell something had happened out there. But so, long story short, how did you all cope with that as a nurse on a critical? That was a critical floor. That was an advanced heart failure floor. Yeah. Everybody up there was in dire need of something.
Yeah, there's a lot of leaning on each other between nurses, especially if you work on a good floor, like, advanced heart failure is, and was when I was there, where we're a family, the nurses, and we lean on each other a lot, especially emotionally, especially when you're going home, to a significant other that may not understand. Nurses support each other. That goes a long way. And part of it is just, being professional and understanding that's part of your job. You have to handle it like a professional and keep it moving.
Yeah, and I really appreciated that, and as well as all the other patients on that floor. We saw it, but I always, even what I was going through, I always was concerned about how did you all deal with some of the things. I remember, and I'll say this one thing, let the other hosts get in. When I first was in the hospital, I know I was an evil son of a gun.
I don't remember that.
By the time you came around, I was the nice guy.
Yeah, you were.
I didn't know what was going on, and it was frustrating. I was getting weak, and all those symptoms, all those things the doctor talked about, loss of weight, I was about this big, and it was frustrating to me. So I was taking it out on the nurses until I started thinking, wait a minute, these nurses are giving me shots. they are bringing me what I need, and I better, turn my attitude. But that wasn't the only reason I turned my attitude. I started noticing, what you all were doing for us and what you all had to go through, because sometimes when you all came to me, you all had just finished with a real difficult patient, but you didn't bring that into the next room. So that's what I saw as a patient, and it changed my whole attitude. And to this day, I appreciate and I hold the nurses up to the highest in what y'all do. By the way, the colonel's wife is a nurse practitioner as well, so it's in his family.
Yeah, yeah. And my mother was a nurse also. But you know what?
Brianna was about to say something, Colonel.
Okay. Mm-hmm.
No, I just wanted to let James know what it was, when you were a resident with us on the advanced heart failure unit, just so you know, it coming on shift as a nurse, it was a good day if James Overton was on your assignment. Just so you know.
I had a nice room, didn't I? I played jazz and
You did, and you kept us laughing. Yeah. So just so you know, that it was memorable for us too.
And he had an instrument in there that I hope he didn't try to play for you. He had the cello in the room, which he couldn't play, but he had it in there.
I never heard him play it.
Okay, good. Colonel, I'm sorry.
Ahead, Colonel.
Oh, no, yeah. You know what? And I would say, when I worked critical care and trauma and actually in deployments and stuff like that, and we always dealt with death and dying. One of the things we got, like I say, what Brianna says, is that we become closer with our staff and we gain strength. And one of the things you probably didn't pick up is Brianna just talked about. She says you were a resident there.
Uh-huh.
And so that, even those small changes in how we think about it and how she thinks about the patients that come through. And when you're a resident, you're part of the family.
Exactly.
And that makes it easier to take care of that person coming through those doors. And I think that's, you can see that subliminal change in how Brianna talks about her family, and I'll say her family that comes through those doors that she's taking care of. Small subliminal thing.
Yes.
One thing is, in the medical field, we totally understand most of the times where patients are coming from, in the sense that patients, especially diagnosed with heart failure, they have a lot of frustration initially because why me? I mean, their life changes. I mean, one day you're told you're healthy, and the next day you're like, your life changes again. So we understand all these emotions that patients go through, and we are there for them. And as Brianna mentioned, we are kind of family, and it's a journey we walk with the patients, and does not stop by the day of discharge or switching physicians. It's we as a team work with the patients and continue following these patients throughout their care post-hospital and after they go home. So it's a family thing, it's a journey, and we understand where everything's coming from.
And it was really interesting to hear you all say that not only do you follow them when they're in the hospital, when they get out, but you continue to follow them once they're out. Is that throughout their lifetime? You have someone appointed to them?
Yes. For the LVAD and transplant patients have a coordinator assigned to them for their lifetime.
And these are individuals who they can call if they're having situations to come up, or do they call the resident to find out how the resident is doing?
It goes both ways.
So basically, the coordinator will be checking on the patient, and the patient, if he or she needs any help or support, they will be calling the coordinator, or if something emergency, goes straight to the physician. And if the patient, he or she, decides to move to a different state or different center, we will make sure that the transition will be smooth and been taken care of, because not everybody want to stay in this area, or like something changed in his or her life, they decide to move to a different state or different location. We make sure that they get taken care of. Also, most of our patients, what we do is we want to get them back to their normal life. We want to make sure they travel, make sure they enjoy what they do. So if they travel, they let us know where they're going, and we hook them up in case of emergency, God forbid. If there's a transport center or an LVAD center in that area, we give them the contacts, or we give that center like a heads up. Hey, we have one of our patients visiting your area. So it's again, we make sure even if they're not close by, away from us, they're taken care of too.
That's good to know. That's great.
Yeah,
James, you're in good hands.
Yeah, every 3 months. And Brianna will tell you, I call her all the time for making sure, if I need to refill prescriptions, or just I have general questions sometimes. And sometimes I might call just to say hello.
Yeah.
Well, look, in the second hour, I've had someone to ask me, please reinforce how we must, especially in the Black community, we suffer a lot with high blood pressure, how high blood pressure impacts upon your heart, and why you have to get your pressure under control.
Yeah, think about it. I mean, you have high blood pressure system, and the heart has to pump extra hard to overcome that high blood pressure. So the heart muscle can get thick, to just try to overcome pressure. And, if you put so much stress on the heart muscle will give out eventually, and you might have heart failure. Also, in your brain too, same thing, the muscles of the arteries can get hypertrophies and thick, and not much blood flow will go to your brain, so you're at a high risk of stroke. Similar thing to the kidneys. I mean, we've seen it. I've seen, because our renal transplant colleagues send our patient to us to make sure they're okay to proceed with surgery. I've seen literally like in the 20s, early 20s, patients who have high blood pressure, which has been uncontrolled, are on dialysis, and they're waiting for a kidney transplant. Again, it's important to seek care. You might be good. It's better be good than too late. If you go to a provider, or you can go to any drugstore like CVS or Walmart, they have all these blood pressure machines. So for free, just put your hand and make sure your blood pressure is fine. If you're previously healthy, blood pressure around 140 over the higher number, it's okay. If it's more than that, we need to address it. If you have comorbidities like diabetes, a heart failure, heart attacks, you want your blood pressure to be less than 130, the top number. And again, it is, prevention is much more important than getting to the disease, because we can prevent you from having a disease. So taking an extra pill now is better than taking 10 later, or being on the transplant list, or requiring transplant. So make sure you don't smoke. Smoking is so common, and again, it becomes a habit, and people start smoking and just like, oh, I'm stressed out, and which we all are stressed out, but there are different venues. There's 1-800-QUIT-NOW number, just for the people listening. 1-800-QUIT-NOW. It's a phone service through the CDC that can help patients or people out there who are smoking to quit smoking. Simple things could be, quitting smoking, eating healthy, exercising. You don't have to go to lift all these weights to exercise. Just walking around. 7,000 steps per day. They found that it improves quality of life and survival. In patients, kind of thing. So get your steps going. Sometimes if it's raining or cold, you can walk in your own apartment, or you can go to so healthy lifestyle starts with us, and healthy living starts with us. And it's a decision I tell my patients and everybody that he or she has to take. I cannot take for them. My job is to tell them and show them the way, and try to guide them and provide them with resources and assistance. But at the end of the day, it is the patient that they have to make that decision. Do they want to take care of themselves? Do they want to live longer? Do they want to feel better? Do they want to see their beloved ones and in their journey? So it's a decision that they have. And I think it a simple decision. I want to live better. I want to get my life back on track. And it's never too late to take that decision. You can start, it can start now, it can start tomorrow. It's never too late. The earlier, the better, though.
And I like to add this to, you said something about smoking, and I did smoke for years. When I was in college, it was like the thing to do. But I smoked for years, and I'm sure that was a contributing factor to the problems I had later on in life. And so don't start it, because it's a very addictive habit and damaging to your body. Doctor, I want to ask you before we run out of time. It's a lot of strides that have been made in heart health and heart treatments over the years. What do you see, the treatments and things going there? I noticed that Sentara did I guess you're familiar with donation after circulatory death.
Yeah.
And that's important for something that probably before, you can revive a donated heart that might stop pumping. Pumping.
Mm-hmm. Yeah. Just one point to add to your point of smoking and when you're young, it's now the vaping thing too.
Yes.
It is as dangerous as smoking, even maybe more. And one thing for our young teenagers in school, and it's vape, there's no like tar, there are other chemicals out there that they're inhaling. And belong, we all part of a group and feel cool and stuff, but they will not pay for it right now. It might be in the future. So vaping is as dangerous as smoking, and just want to add to that too. So and it's a habit and it's addictive. It's very addictive too.
And before you go on, vaping,
Yes.
They will vape, not knowing what's in that vape machine, but they won't take the vaccine because they think something is in there that shouldn't be there. So
yeah, it is
ironic.
Yes.
Yeah.
And I think to protect our community and protect ourselves, it's important to be awake and to be open to to all the medical technologies right now. I mean, the vaccines, and all the providers I know I've taken the vaccine myself, and I've been exposed to COVID all the past year and a half. And, I've been seeing patients in the hospitals. I've been patient coming to clinic, and they turn out to have COVID and send them to the emergency room. And thankfully, through the vaccine and wearing a mask and hand sanitizer and cleaning have prevented me, thankfully, from getting the disease. And I've been exposed, and we were like on the front line dealing with the vaccine. So with the COVID-19 pandemic. So all these measures have proven to help us, not to contract the virus. So again, I reiterate importance for getting the vaccine. For you out there who has not got a vaccine, protect yourself and protect your family. And, we are all predisposed, and there's nobody immune to it. Nobody immune to getting it. And if you are fearing to get side effect from the vaccine, the side effect, trust me, are significantly much milder than having the disease itself. Sorry, I digressed. But to go back to
It's okay.
Yeah.
Actually, I'm glad you you went back a little bit. I'll even put it more bluntly, is that if you don't get the vaccine, and especially if you live in the rural areas where you got a community hospital out there, when you get a COVID, it's not if, it's when you get it, because you're at a small community hospital or a place that does not have ECMO, you can look at your numbers and say, get ready to get that iPad to say goodbye to your family. Because one, there's a shortage of folks out there that are trained nurses to take care of you. There's shortage of critical care doctors out there, and there is no ECMO machine that's going to oxygenate your blood once you shut down. So you are going to join the club of 2,000 people every day that die.
Yeah, and one thing too, I think, Mr. Overton, like we're talking maybe a little bit about the COVID, but it's important too. I think what's happening now is not many people shedding light of the severity of the COVID-19 pandemic.
Yes.
It happened before, like in last year, everybody talking about it every day, and like now we are seeing numbers higher than we saw last year, significantly higher. And we need to get it back out there to the community to hear us. And thank you guys for doing this tremendous, amazing job, giving us the forum to talk about it, because not many people are talking about it.
Right.
And, you know, we are seeing it, we are, you know, dealing with it. We have our, over the weekend, have 2 transplant patients with a COVID-19 pneumonia. I mean, these patients definitely, sometimes the vaccine in transplant patients is not as effective in somebody not on transplant. So not because they are, you know, not taking care of themselves, but they got it from family members or people in the community that they are not vaccinated, and they transmitted the disease to them. So if you don't want to care about yourself, which I don't think anybody want to care about themselves, think about the other people. Think about your mom, your grandma, your grandfather, or your colleague, or your significant other, because you're not just putting your life in danger, putting other people in danger and the community in danger as well too.
But you know, doctor, one of the problems is we have elected officials out here, especially elected governors that are across the country, keep power or to gain higher office, that is giving different messages out there and calling about the or the ideal or the concept of freedom for masks and vaccines rather than looking at the science. And that's our real problem when we have a non-concurrent message across the country. And people listen to them, especially if you have the old state-run TV called Fox, and telling them, you know, telling people not to do things. And that's contributing to this problem across this country. And those people are trying to do, like I say, join the club of the 2,000 people dying every day across this country.
Yeah. So what are our jobs as a healthcare provider and people is just to share at least our experience, because we are in the front line and see what's happening. And we share our science, our experience, and we want patients to live, to get better, independent of their political background, independent of their race, gender, ethnicity. We don't look at any of that when we take care of patients. We take care of patients independent of any of this stuff. We just want the best for every single person. And I encourage them, again, reach out to any person to get the vaccine at the time. And if there's significant contraindication to the vaccine and he or she decides not to, for whatever reason, just please be safe. Please wear a mask all the time when you're out there. Please use hand sanitizer. Please take care of yourself and your beloved ones as well too. So it's getting worse, and we're you know, by the day. But just take care of yourself and be safe and healthy.
Yes.
Thanks. I knew that was going to be an important part of our conversation. But before we go, I wanted to didn't want you the DCD.
Yeah.
Method of a donated heart that might stop pumping. Now y'all can revive it.
Yes. Yeah. So basically, nowadays, because of the limited donor availability, you know, in the past there are around like 2,500 transplants. It's not 2,500. I'm sorry, 100 transplants done in the States. And we know that the patients who require transplants are significantly higher. The number does not match. The need does not match the supply. So a different transfer center across the country and the world started thinking of outside the box. For example, at Sentara, we accept hearts, like we have hepatitis C hearts, for example. As patients with hep C donors, they were not approved. I mean, not many centers were taking Hep C donor, hepatitis C. But now with the treatment for hepatitis C, the different medicines that are there that have shown to have more than 95% cure rate, we're doing hepatitis C donors. So we're increasing the pool. Other ways to increase the pool is getting donation after circulatory death, or DCD. And in the past year or so, it was part of a research trial which led by big transplant centers in the States here, but also it was in Australia and Europe too, and they had a very favorable outcomes with it. And Sentara is one of the nation's also few centers who were participating in that trials. That again, why are we doing all these things? We are doing these things to help provide services for our patients, try to give them, more options and organs that can help, like, improve their survival and quality of life. So DCD in the States is still in its infancy kind of thing, but it's going up now. And we're going to see more of it in the coming years too.
Doctor, will that increase the window that you have to have in order to get that heart transported and then transplanted?
Yes.
Yeah.
So basically, it is the heart will be on like a machine that can, you can transfer the heart, transport it through like longer distances, basically. And it's kind of like a bypass machine, pumps the blood through it and continues to circulate. So it's kind of called the heart in a box. And ideally, we do this to try to decrease the time on the transplant list, because to transplant more patients.
Right.
So you want to add anything about it?
You have sort of a region that you like to travel to get a heart, because it might put you outside of that 4-hour window if you go further. So that might be to extend that, for patients here in Norfolk, it might be extended and increase the possibility of a transplant.
Absolutely. In the past, the transplant used about the mile radius area. Now we're traveling longer distances. We're traveling to different states across the country to be able to, we have different also devices that can preserve the organ too, to maintain that organ at a specific temperature. So all these technologies are out there right now. And luckily and good in Sentara, we're utilizing them because we want to make sure, again, to provide the best services for our patients too.
And Brianna, you actually travel with the surgeon to receive the heart?
Typically, no, although I have twice, just for a observation kind of experience thing. I did travel twice, to see a procurement. Typically, though, the transplant coordinators stay here at Sentara and help coordinate things from home.
But for the DCD, for example, we have our research coordinator travels. We have 2 surgeons that travel with the team. We have a perfusion. It's a whole team. And during our training, when I did my transplant training 7 or 8 years ago now, we used to go with the surgeon, and it was like mandatory, so we can see the process as well too. About the procurement and
By the way, shout out to Dr. Philpott. That was my surgeon. So.
Yeah, absolutely. Yeah.
Okay, we're gonna wind down, but any of the hosts have any other ending questions or comments you'd like to give?
Well, I would just like to say thank you so very much for coming on. The information was crucial for us to get out into our community now. And I'm praying that they're listening and that they realize those things that they need to do to take care of their heart, take care of their diabetes and take care of their lives, so that they will not end up coming to see you. Although you're very nice people, we would love to see you on a social setting,
Absolutely.
but not at the heart hospital, okay?
Yeah,
but I want to thank both of you. You all are given a wealth of information, and prayerfully the community is listening and they will take charge of their health. Thank you so very much to both of you.
Thank you
And
for,
Leah is one of those 5,000 steppers.
Yeah, I was doing 10,000 a day. Oh, yeah, 10,000 a day. Yeah, 10,000 a day.
Yeah. I know there might be some other questions. We're available on social media. I have my Twitter account. Patients, I post sometimes like healthy tips for patients, which is AMIN and YEHYAMD. So my first last name MD, the Twitter. Patients can, if you have any questions, please reach out to me. Again, it's important topic. We're always available if you all have any questions. Raising awareness is important, and whatever you guys are doing is so important. We appreciate you and thank you for doing what you're doing and helping raise awareness about the disease in the community.
But we'll definitely have you back because this subject is dear to my heart.
Yeah. Thanks for having us.
Oh,
Good one.
James. You're
Yeah.
about as bad as the man on the commercial about koi. The koi fish, don't be coy.
I couldn't help that.
I know.
Colonel, do you have one?
Colonel.
Yeah, I like to thank the both of you because one, I've always been a proponent of education, graduate medical education for the docs, and also nursing education for our professional nurses. Because one of the things is that COVID has put a damper on our continuing medical and nursing educations. Put that, and so we need to reemphasize those two professions because it also highlighted the need for healthcare education across this country, and because there's grave shortages across it, and now it's come in vogue now, and now we see it as a nation that we need more trained professionals out here to take care of all of us, especially as we get older. And so, but for the two of y'all, I thank you for doing what you do over there every day, and you're unsung heroes.
Thank you so much. We appreciate you guys. Thank you.
And by the way, the Colonel has 2 daughters that are in the medical field.
That's nice.
good.
Yeah.
Yes.
Good job. Well, thank you guys again. Y'all have a great day and thanks for having us.
Thank you.
Thank you again.
You stay safe and take care of yourselves as well.
Appreciate
Yes,
you.
and Portsmouth Coffee Talk is here for our voice.
Our community.
In our future.
And thanks everyone for watching, and tune in next week as our guest will be who, Leah?
Will be Miss Jackie Kendall and Mr. Is it Brendan, who are a part of the Reclaiming Manor team. So we figured since they just got their name back to their school, it's a good time to bring them on so they can talk about how excited they are that they have their school back.
Well, they will never beat Norcom. They play Norcom tomorrow night. So
Oh my goodness, I
get ready
pray.
for a lucky
I
man,
pray,
my friend.
I pray that Norcom wins tomorrow night.
All right, thanks everybody. Take care. Have
Thank
a
you
great
all
day.
so very much.
All right, thanks.
Blessings to each of you.
Good. Thank you.
Bye-bye. Another good show, guys. Oh,
Yeah.
wait.
Still-
Excuse me. Wait.
Informative. I'm glad we got that.
Wait a minute.
There we go. They're still
Wait a
recording.
minute. Stop recording.
And you don't want to be
Wait a minute. Stop it. Wait a minute.